recording. All right, good evening, everyone. Mrs. Ignacio here. We are getting right into it with our maternal newborn review. This is a pop-up session, and I just want to mention a couple things. I'm displaying this visual aid of complications within pregnancy. I just want to mention a few things before we jump into this, though. When we think about pregnancy, I want you to think about, okay, there's three things that you need to know, and those are the presumptive signs and symptoms of pregnancy, the probable signs and symptoms of pregnancy. I'm sorry, I shouldn't say probable, because probable is objective, so it's what the provider will notice, so there's really no subjective information. So the positive signs of pregnancy, so these are signs related to the presence of a fetus. So let's talk about each one of them. When we think about presumptive signs or symptoms of pregnancy, well, this is going to be subjective, and I'm going to put it in the chat, and hopefully this is a good review. Okay, presumptive. So things that makes the patient say, yeah, I think I'm pregnant. So it can be amenorrhea, fatigue, nausea, vomiting, urinary frequency, breast changes, darkened areolas, enlarged Montgomery tubules, quickening, which is a slight fluttering movement of the fetus felt by the patient, and that's usually between 16 and 20 weeks. I'm going to show you a different visual aid that shows you the physiological changes in pregnancy, because I think that would be a good visual to look at as we talk about these signs of pregnancy. So again, that was presumptive. I think I'm pregnant. So this is what the patient will think and see. Amenorrhea, fatigue, nausea, vomiting, urinary frequency, changes in the breast to include darkened areola, enlarged Montgomery tubules, quickening, slight fluttering movements of the fetus that can be felt by the patient between 16 to 20 weeks of gestation. If this is not the first pregnancy, the patient may feel that quickening a little bit earlier. Okay. Any questions about the presumptive signs of pregnancy?
No.
Okay, fantastic. We're now going to jump to then the probable signs of pregnancy, and those are objective signs. These are things that the healthcare provider will observe. So these probable signs include cervical changes, Hagar's sign, which is a softening and compressibility of the lower uterus, and that is Hagar's sign. And I'll be putting these in the chat. So in case you're wondering how to spell these, Chadwick's sign, that is a deepened blue, violet bluish color of the vaginal mucosa that is secondary to increased vascularity of the area. So that is Chadwick's sign. And so, you know what? Good test questions are made of all of these signs. Good NCLEX questions are made of these signs. So Chadwick's sign again is a deepened violet bluish color of the vaginal mucosa secondary to increased vascularity. There's also Goodell's sign. I know there's a lot of signs when it comes to our pregnancy, right? And again, these are objective. And when we think about Goodell's sign, this is the softening of the cervical tip, the softening of the cervical tip. There's also ballottement, and that is the rebound of the engaged fetus. So if you press upon the abdomen of your patient, you may feel a kick. They may say, hey, why are you pressing on my head? And they may kick you, right? Or they'll kick their mom. They won't kick you. That's ballotment. Okay, let me just make sure oops, sorry. There's a typo in the chat, but ballotment is in the chat. Okay, and so the next couple ones for probable signs of pregnancy is going to be Braxton Hicks contractions, and those are also called false contractions. And they're painless, they're irregular, and they are usually relieved by walking. So that's false labor, your Braxton Hicks. And I always think of Tony Braxton for some reason. I don't know why when I think of Braxton Hicks. So if that helps you to remember it, hooray. Okay. And then the last probable sign is going to be a positive pregnancy test. Okay, let's talk about the positive signs of pregnancy. How do I know without a shadow of a doubt that this patient is pregnant? Well, there's three things. Fetal heart tones. Those fetal heart tones can be heard and they can be seen, they can be visualized by an ultrasound. And then second thing is going to be visualization of that fetus by an ultrasound. So we've got the heart tones, we've got visualization of the fetus. The third thing is going to be fetal movement that is palpated by an experienced examiner. So that's not me, that is not you, but it's going to be that midwife. Maybe it's going to be that OBGYN. So that's going to be the three things: fetal heart tones, visualization of the fetus by ultrasound, and then fetal movement. Okay. Any questions about those three things?
No, ma'am.
Okay, fantastic. All right, we're going to jump into the complications now. I just wanted to kind of touch on those 3 points because I think those are important, especially they may be test questions for you that have a test coming up. So let's talk about complications of pregnancy. So pregnancy sometimes, is a great thing. We're excited, and we really, though, need to carefully monitor the mom and the baby. That's going to be important. Carefully monitor the mom and the baby. All right, Kathy's joining us, so she's jumping in right at the correct time. All right, welcome, 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 Kathy. We just talked about the different signs of pregnancy: presumptive, probable, and positive. Do you have any questions before we get into complications of pregnancy? Oh, Kathy, I don't hear you.
No, 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 ma'am, I don't. I'm having a time with my internet service.
Oh,
my
no.
my main internet service has been out most of the day, and I called the people, so I'm using my hotspot on my phone. So
Oh,
that's
okay.
why I may
Oh,
be breaking up a little bit, but no, I don't have any questions. Not
okay.
right now.
Okay, excellent. So you can also put questions in the chat if you have questions later on as we go through. Okay, thank you. And I'm glad that you're here. All right, let's talk about ectopic pregnancy. Okay, let's talk about ectopic pregnancy. So with ectopic pregnancy, this fertilized ovum is going to implant outside of the uterus. And we know that the uterus is where that fertilized egg needs to actually implant to have a viable pregnancy. So this fertilized ovum can implant in the pelvis, in the abdomen, and it's usually or it's often in the fallopian tubes. Okay, so that's where this fertilized ovum kind of just says, okay, I'm going to make this my home. Okay, let me pause for a second to greet Julia. Julia, did you have any questions?
Hey, no, not right now.
Okay, fantastic. All right, so we're talking about the complications of pregnancy. The first one is ectopic pregnancy. So this fertilized egg is going to implant somewhere other than the uterus where it belongs. That other place is usually or often the fallopian tubes. So what contributes to a patient having an ectopic pregnancy? Well, they can have scarring of their fallopian tubes because of previous STIs or pelvic inflammatory disease, or maybe they can have an IUD. And here's a quick sidebar. I saw an article recently. A baby was born holding his mom's IUD in his hand. So that was really a funny story. Okay, so other contributing factors to ectopic pregnancy besides the IUD could be endometriosis or tubal surgery. Okay, so the manifestations, what are we going to see? Those clinical cues, because that's what next generation NCLEX is going to test us on. Do we recognize these signs and symptoms, this assessment information? What am I going to see? Well, for your ectopic pregnancy patient, they may have a delayed or missed irregular menstrual cycle. They may have a unilateral stabbing pain and tenderness in the lower abdomen. And the reason for that is that fertilized ovum is probably implanted in the fallopian tube. And we know as that ovum divides, it's going to get too large and it's not going to be able to remain in that fallopian tube. The patient actually risks rupture of the fallopian tube, which is a medical emergency. So we could see bleeding in this patient in the case, of course, of a ruptured fallopian tube. And the patient could go into shock. So how do we know the patient's going into shock? Can somebody tell me?
Blood pressure's down, heart rate's up.
That's right. Thank you, Lakeisha. So hypotension, tachycardia, pallor, and that's, not just your pregnant patient, but any patient that's going into shock. So your post-surgical patient that has internal bleeding, they're hemorrhaging, their blood pressure is going to go down, heart rate's going to go up because it's trying to compensate, and they're going to have pallor. Their skin is not going to be appropriate for their ethnicity. So what is the collaborative care? What do we do for a patient under these circumstances with this ectopic pregnancy? Well, number one, we're going to provide psychological support. That's really, really important. Replace the fluids. And I would say number one, that's not necessarily the first thing that you're going to do. So when we think about prioritization, this patient could be hemorrhaging. So we have to address the hemorrhage first. So number one would be, in order of priority, is going to be to replace those fluids. It could be due to, it could be by a transfusion, or it could be an IV bolus of maybe normal saline, but those fluids are going to be important to be replaced. And we are going to administer methotrexate. Methotrexate is usually the medication of choice. I'm going to put the abbreviation here. If you're not familiar with methotrexate, please also take some time to look that up. And the other thing is, if it is a ruptured ectopic pregnancy, we think, okay, the patient has to be prepared for surgery and then post-operative care. And then, of course, lastly comes that psychological support. Are any questions about this ectopic pregnancy? All right, so let's get into now hypertension in pregnancy, because that's a big one. A lot of test questions can come from that, because this hypertension in pregnancy can cause a lot of complications. So let's kind of break it down. So when we think about hypertension in pregnancy, we're thinking about gestational hypertension. We're thinking about mild and severe preeclampsia. And so these are getting more and more serious as I mentioned them. We can have eclampsia, hemolysis, elevated liver enzymes, and low platelets, and that falls under HELP syndrome. Okay, we'll talk about HELP syndrome. Okay, so when we think about gestational hypertension, we're looking at possibly after the 20th week of pregnancy. The patient will present with an elevated blood pressure, and this blood pressure is going to be, 140/90 or higher. And this is going to be on 2 separate occasions, and those 2 separate occasions have to be at least 4 hours apart within 1 week. So in gestational hypertension, there is no protein in the urine. The blood pressure for most patients will return to the baseline at 6 weeks postpartum. Okay, so that is your gestational hypertension. Now, mild preeclampsia, now we're getting more serious. Mild preeclampsia is everything that we just mentioned for gestational hypertension, that blood pressure 140/90 twice. We talked about that blood pressure, being 140/90 on 2 separate occasions, at least 4 hours apart. But with mild preeclampsia, they have the same thing as far as their blood pressure goes, but they're going to have protein in their urine. Okay, and so their protein could be 1+ or 2+ with mild preeclampsia. Now, severe preeclampsia, we have an even more elevated blood pressure, and we're thinking this blood pressure is going to be 160/110. So that's much higher than the 140/90. And this is going to be also on 2 separate occasions. And so this patient will also, this severe preeclampsia patient will also have protein in their urine, but their protein is going to be 3+. Okay, so they have much more protein in their urine. Their serum creatinine is going to be greater than 1.1. Okay, we're also looking out for cerebral or visual disturbances in this patient. They may have a headache or blurred vision. That's going to be a really big red flag. If you have, a mother-baby kind of question and the patient has blurred vision, they have a headache, they have facial edema and edema of their extremities, that's all red flags that this patient has severe preeclampsia. There sometimes may be pulmonary or cardiac involvement as well. So we have to make sure we perform very good pulmonary and cardiac assessments. And again, they may have extensive peripheral edema. They even may have hepatic dysfunction. So we have to monitor their liver function tests. They also may complain of epigastric and right upper quadrant pain, okay, with your severe preeclampsia. They also may have thrombocytopenia. And what is thrombocytopenia?
Isn't it where the platelets, you get a abundance of platelets?
So you're right when you say platelets, but it's low platelets. Okay, it's low platelets. Okay, so very good. So we're concerned when we have a patient that has low platelets, I'm always concerned about them bleeding. Okay, I'm concerned about them bleeding. Okay, so any questions about gestational hypertension, mild preeclampsia, and severe preeclampsia? Okay, so let's jump into eclampsia. So eclampsia is inclusive of everything that we just mentioned for severe preeclampsia plus seizure activity. Okay, and so this patient, when we think about this patient that, this pregnant patient with this gestational hypertension, mild eclampsia, severe preeclampsia, we want to have them in a low stimuli environment, right? So the lights will be dim, no loud noises, not a lot of visitors. We just want to make sure that everything is low stimuli. But with eclampsia, we now have seizure activity. So think about seizure precautions, everything that goes with seizure precautions. So with your patient, your pregnant patient that has eclampsia, they may have this persistent headache, blurred vision, severe epigastric or right upper quadrant abdominal pain, and they could have an altered mental status. Okay, so you really want to look out for all of those clinical cues because those are the things that the questions can be made up of. Now, we're still with the blood pressure because one of the other complications that you could see if your patient has blood pressure that's out of range during their pregnancy is they could end up with HELP syndrome. So each of the letters stands for something, and the H is hemolysis. This is the breaking down of your red blood cells or of the patient's red blood cells. And so what happens, the patient can become anemic and they can also have jaundice. So if I have a pregnant patient that I'm noticing that is jaundice, I'm thinking, okay, what's their blood pressure like? Maybe they have HELP syndrome, okay? So the EL stands for elevated liver enzymes. So I know that I have to carefully monitor this patient's liver enzymes, and that is my ALT and my AST. So I'm going to be carefully monitoring that, my ALT and my AST. And I'm going to be monitoring for any epigastric pain, any nausea, and vomiting. So that is the EL. Now the LP stands for low platelets. This is, again, thrombocytopenia, and we're talking about platelets that are less than 100,000, okay? So this patient will have thrombocytopenia, low platelets. So now, when we have low platelets, I know that this patient is at risk for bleeding, for hemorrhage. So they're going to have abnormal bleeding and clotting time. They could have bleeding gums. They could have petechiae. That's that pinpoint rash that tells us that the patient has bleeding going on. And they could possibly have DIC. So DIC, we kind of talked about, I think, with a group last night, and I will just mention it. Well, let me ask you all, what is DIC? Okay, and I'm typing out the name in the chat, what DIC stands for. Oh, intravascular is spelled wrong. Sorry, folks. All right, so disseminated intravascular coagulation. And
It's the ability to clot, right?
say that again, please.
The ability to clot.
Yes. Okay, excellent. So that's right. So your patient that has DIC, they're going to be clotting and then they're going to be bleeding because their body's going to be using up all of the clotting factors and using up all of the platelets. So it's really tricky. And in the first hour, when they're in that first phase, you would expect during this clotting phase, they're going to be administering IV heparin to thin out the blood to prevent them from clotting. But what happens is when this patient has DIC, they're clotting, and they're using up all of their clotting factor. They're using up all of their fibrin. They're, not making as much fibrinogen. And now they're bleeding. They're at risk for bleeding. Okay. So it's really an unfortunate kind of scenario for this patient. Okay. So any questions about these conditions that have to deal with blood pressure in pregnancy? Okay. So let's talk about the contributing factors. Why might this patient have these blood pressure issues in pregnancy? Well, there's a lot of different risk factors. So they may have multiple risk factors. So those moms that are really young, younger than 20, are at risk. Moms that are older than 40, they're at risk. If it's the first pregnancy, they're at risk. If it's a morbid obesity pregnancy, they're at risk. If the patient has a multi-fetal gestation, so if they're having twins, triplets, if they're octomom, they're at risk. If the patient has chronic renal disease, they're at risk for these blood pressure issues. If they are already a hypertensive patient, they're at risk. If they have a family history of preeclampsia, they're at risk. If they have diabetes, they're at risk. If they have RH incompatibility, they're at risk. I'm going to pause for a second for somebody to tell me, what is RH incompatibility?
When the mom is negative and the baby's positive.
Yes, that's correct, Jennifer. So what do we do in that case?
I'm not sure.
I'm shot program.
Get a Rogaine.
Yeah.
Yes, so Rogam shot. I heard Lakeisha and Kathy say that. So what's the magic times? There's 2 times that you got to know for your test questions when it comes to that Rogam shot.
I know one is after. Look, I'm RH. I'm RH, and I should know it because I get it with every one of my pregnancies.
Okay, so it's after birth. That's right, Lakeisha. And there's another time that is during the pregnancy. How many weeks is that? It's in the chat. 28 weeks. 28 weeks. So Rogam can be given at 28 weeks and after birth. And it's really important because if this mom is RH negative and her fetus is RH positive, we have to give her the Rogam to make sure that her body does not identify future pregnancies as foreign bodies. Okay, so that's going to be super important for the health of that, upcoming developing fetus. All right, so other contributing factors to, gestational hypertension or blood pressure issues in your patient could be a molar pregnancy. And when we think about a molar pregnancy, this is actually not a pregnancy, it's a tumor that is growing within the uterus of this patient. Okay, and also if the patient has a previous history of gestational hypertension, again, they're at risk. So when we think about these manifestations, we have to make sure that we're looking out for the patient's urinalysis. We're looking for protein in their urine. We're monitoring their blood pressure very carefully. We're monitoring their liver enzymes, their creatinine, their BUN, and their uric acid. The things that we want to do as a nurse, if we are caring for this patient with blood pressure issues, we want to, of course, monitor their blood pressure and administer any medications. The medication usually of choice for blood pressure issues in pregnancy is going to be nifedipine. So we think about nifedipine. We also want to teach the patient about balanced diet and exercise, limiting caffeine intake, and we want to assess this mom's weight daily. We also want to monitor her I's and O's, her reflexes, and really do a good neurological check to make sure that there's no changes in her level of consciousness or any issues with her central nervous system. We will encourage this mom to be on bed rest, and she will not be in the supine position. She will be on the left side. If a pregnant mom is in the supine position, what am I afraid of? If a pregnant,
Cord compression. or hyper-
Cord
it's hyper-
compression?
yes, yes, absolutely. So, well, not necessarily cord compression. There's going to be compression, but I'm thinking compression of the vena cava, which is going to then cause a drop in blood pressure for the mom, right? So that's why, especially second and third trimester, they should not be lying on their back in the supine position. They should be lying on their left side. Okay, does that sound familiar?
Yes.
Yes, I just remember when I was pregnant, I was like, I'm on my left side. This is the only thing I can do, right? So, but that's going to be best. I have also seen questions if the mom is pregnant and her blood pressure is dropping and the fetus appears to be not getting enough oxygen. We want to, if we can't place, if the choice isn't placed on the left side, elevate the hip, because if you elevate the hip, that's going to take pressure off of that vena cava. And so that should alleviate that issue. Okay. Again, with your patient that's pregnant with blood pressure issues, we're going to initiate seizure precautions. And again, low environmental stimuli, private room, very dim, very quiet. And we're going to monitor for HELP and for DIC. Okay. So let's just talk about seizures for just a moment. What do seizure precautions consist of?
What do you mean, like raise up the side rails, stuff like that? Is that what you're asking? Like what we
Yes.
did, remove
Ye-
the pillows?
Yes. So I know some places you remove the pillows, some places you have wedges, right? So whatever you do with the pillows, depending, because I've seen different things that people actually do like in real life. And then, the textbook says one thing, but when you implement those seizure precautions, you are going to elevate, of course, you're going to raise up the two side rails, not all four, but the first two by the head of the bed. You're going to have a fall mat in place. The bed's going to be at the lowest possible level. Of course, low stimuli, those are all things, that goes with seizure precautions. We're going to have oxygen at the bedside, suctioning equipment at the bedside. All of that goes with seizure precautions, okay? All right. And when a patient comes out of their seizure, they may be confused. So we may have to reorient the patient, okay? I mentioned nifedipine being a medication that can be used to control the blood pressure. Also, magnesium sulfate can be used because we know that with this hypertensive situation, we're at risk, or the patient is at risk. So that magnesium sulfate is going to be used prophylactically to prevent any seizure activity. So that's why, again, that central nervous system, that neurological assessment is so important. Okay, so we want to, whenever you think mag sulfate, I want you to think deep tendon reflexes. So let me just share with you, I think there is medications for maternity. Let me just see. No, that's not. Okay, so there's not, I thought there was, it might be on my other files. Okay, okay, it's under reproductive medication. Let me put this link to you because this is also a good thing for you to study as you are studying, mother baby. You need to know the medications. And so let me just see if there's anything. Oxytocin. I don't think there's one for mag sulfate. But methogen definitely when we think postpartum hemorrhage. Okay. All right. But I'm going to go back to that main picture so I kind of stay focused and go through those disorders, those complications before we go into questions. Okay. Let me just make sure I haven't missed anything. Any questions about blood pressure issues with your pregnant patient? Okay, we're going to jump into placenta and cervical issues now. So we're going to talk about abruptio placentae and placenta previa. So sometimes it's easy to get those two confused. So hopefully we'll get the distinction now. But let me ask you all, does anybody know the distinction, the difference between abruptio placentae and placenta previa?
One has pain and one doesn't.
Yeah, yes, that's right. That's right. So which one doesn't have pain? Does anybody know?
PP for painless. That's what I was.
Y- That
That's what I
that's that's right. That's right, Lakeisha. So placenta previa is going to be painless. Okay, so if your patient has abruptio placentae, these are the contributing factors that can lead to this abruptio placentae. It could be due to trauma, preeclampsia, multiparity, so they have more than one fetus, or even cocaine use. Okay, even cocaine use. So what is this patient with abruptio placentae? What is it going to look like? Well, they're going to have vaginal bleeding, and their vaginal bleeding is usually dark red in color. And it can range from, minimal or scant to a large or moderate amount, or moderate or large amount. Their pain, they're going to have a lot of pain with abruptio placentae. You're going to even maybe see the term rigid board-like abdomen. And when I think of that, I think of peritonitis. I think of, wow, their abdominal cavity is filling up with blood. And of course, this is a medical emergency, right? And so the danger with this abruption is that the mom can bleed to death. She can go into shock and she can actually die. Okay, so this is really important to understand when we talk about this abruption. So what's the treatment? Okay, what is the treatment for abruptio placentae? So the first thing, I've seen a lot of questions. The first thing is I want to make sure that the mom has a patent IV because I know we're going to probably have to bolus fluids. We're probably going to have to do transfusion. We're going to monitor for DIC. We're going to get her ready for an emergency C-section and provide emotional support. But the first thing I want to do is make sure that that mom has a patent IV. Okay. Now, when we talk about placenta previa, what happens with placenta previa is that the placenta is not completely, it's not in the correct position. So it could be that placenta could be partially or completely covering the cervical os. Okay, and so when this patient with placenta previa has vaginal bleeding, it's usually bright red, and it can be minimal to moderate to severe as well. There is often no pain, right? Just like Lakeisha told us, placenta previa, put another P, and it's painless. Okay. And so, but still, we're looking out for signs of hemorrhage, shock, and death in the mom. And with both of these conditions, we are concerned about the fetus having central nervous system damage due to lack of oxygenation, and it could lead to death, right, for the developing fetus. So for placenta previa, it will be treated just like abruptio placentae, but they may not necessarily have to have that emergency C-section. Okay. All right. Any questions about those two conditions? Okay, we're going to jump into hydatidiform mole or molar pregnancy. So this is a benign abnormal growth of chorionic villi. So this patient is basically not pregnant. So remember when we talked about those positive signs of pregnancy? They're not going to actually have a fetal heart rate. They're not going to have a visualization of a fetus in the ultrasound. They may have elevated HCG levels. They could have a positive pregnancy test. That's why knowing the positive signs of pregnancy, okay, this patient is for sure pregnant. So this patient with the hydatidiform or molar pregnancy, they can have vaginal bleeding, brown grape-like clusters, they can have anemia, they can have rapid uterine growth. So they're like, man, are you having twins? You're just so big. This patient may have extreme nausea. They can have hyperthyroidism, and they can have preeclampsia prior to 24 weeks. So how do we know that this patient has this hydatidiform mole? Well, or molar pregnancy. There'll be an ultrasound, and they're going to have persistently high HCG levels. So when we perform care for this patient, we can expect that there's going to have to be a dilation and curettage, which is a D&C. Dilation is when we open up the cervix, and curettage is scraping away those tumor cells or those growths, okay? RhoGAM may be administered if the mom is Rh negative. And after we perform this D&C, this dilation and curettage of this patient, we want to follow all of the postpartum protocol because we're making sure that, okay, were all the fragments removed from the uterus, because if not, this mom is at risk for postpartum hemorrhage, even though she didn't give birth, but it's the same kind of idea that they're at risk for hemorrhage. We also will continue to monitor their HCG levels. And this mom that, has this hydatidiform molar pregnancy, they're advised to not get pregnant for a year. That's going to be really important. Okay. Let's talk about cervical cerclage. Cervical cerclage is done if the mom has an cervical insufficiency or an incompetent cervix. So sometimes there's premature dilation of the cervix, and we know that that cervix, the magic number we're looking for is 10. And 10, that's going to be the magic number again. But if it's too early and the mom doesn't have a competent cervix, they will actually pretty much sew her up with purse string sutures. Sometimes that's good enough. Sometimes this mom may actually have to be on bed rest for the rest of the pregnancy. So we have to look out for this with this patient. Okay, hyperemesis gravidarum. Anybody knows what that is?
Is it a lot of vomiting?
Yes, that is correct, Kathy. And so Princess Kate, I think it is, not Princess Meghan Markle, but the other princess, she had this with all of her pregnancies, excessive pregnancy-related nausea, vomiting. And it can begin the first or second month of pregnancy. And so, of course, this is the mom that we're concerned that they have so much vomiting that they're not gaining enough weight. They're actually losing weight. They can become dehydrated. They also may have constipation. They can have ketosis. They can have nutritional deficiencies, metabolic imbalances. So for our nursing considerations, of course, we're going to administer antiemetics such as ondansetron or your Zofran. We're also going to give a vitamin B6, no more than 100 milligrams daily. We can also use relaxation techniques, massage, and we want to teach this patient to eat small, frequent meals. Dry foods such as crackers, ginger ale may be helpful. Seltzer may be helpful, sparkling waters also. So again, this patient is going to be on eyes and nose, daily weights because of this excessive vomiting. All right, let's jump into diabetes. So diabetes. So if your patient already has diabetes, of course, they're going to be at risk for gestational diabetes. Some of the other contributing factors for a patient having gestational diabetes is obesity, if they have a maternal age that is advanced, family history of diabetes, and if they have a previous history of an infant who was large or stillborn. So what are the manifestations of gestational diabetes in your pregnant patient? Well, they can have hypoglycemia, so low blood sugar. And remember, low blood sugar, nervousness, headache, weakness, irritability, hunger, blurred vision, tingling of the mouth or extremities. Hyperglycemia, they can have thirst, nausea, abdominal pain, frequent urination, flushed dry skin, fruity breath. So remember, polyuria, polyphagia, polydipsia. So let me put, does anybody not know what any one of those are? Because you might know those already from med-surg. Polydipsia. Okay, what's polyphagia?
Eating, excessive eating.
Yes, excessive eating. Thank you. Okay. What's polydipsia?
Excess thirst,
Mm-hmm.
Yes, perfect. And then polyuria?
excess urination.
Mm-hmm.
Yes. Okay, perfect. Okay. So let's talk about the laboratory testing when we think about this. So we're going to have that glucose tolerance test, and that's going to be 50 grams of that oral glucose load. And this is going to be performed at the 24 to 28 weeks of gestation. So fasting is not necessary. And we're looking for a blood glucose that is less than 140. If the patient has 140 or greater, they're going to have to do that secondary glucose test, and this is going to be the 3-hour glucose test, a glucose tolerance test, and they're not going to have 50 grams of oral load. They're actually going to have, I think it's 100 grams of, let's see. Yes, it is 100 grams. I just wanted to make sure. And they will have to fast, and they will be NPO. So they can't have cigarettes or nicotine or anything by mouth, okay? And you're wondering, do pregnant moms smoke? Yes, they do. One time I saw a pregnant nurse that was smoking. This was a long, long time ago. And I was like, oh my gosh, but pregnant moms do smoke and we should not judge them. That's just the way that it is. Our best thing is just to provide them education, and then they make their own choices. All right, so going back to the gestational diabetes, we're going to monitor their H1C, right? Their HbA1c, so their hemoglobin A1Cs. We're going to look out for ketones. We're also going to monitor fetus development, fetal well-being. We're going to do a non-stress test to assess fetal well-being. And we really like to control this gestational diabetes with diet and exercise and monitoring their blood glucose level. Insulin, if it's required, then it will be given. But again, they try to manage this with diet and exercise. Okay, so I'm going to stop here to see if there's any questions before we jump into our questions. Okay.
Complications with pregnancy.jpg.
Sorry.
Open with ZIP extractor.
I hit the wrong thing. Let's see. All right, hopefully that does not go. All right. Okay, I'm still sharing my screen. You should see question number 1, I hope. Take some time to read that, and then put your answers into the chat, please. Okay, Kathy, I see you. Okay, Jennifer, I see you too. Thank you. Okay, Julia, I see yours. Thank you. Okay, great. Everybody got this one. I think this was super easy. Anybody have any questions about number one?
I accidentally direct a message somebody, so I'm sorry, y'all. I didn't mean it. I thought it was on everybody.
Okay. Okay, no worries. Okay, so we talked about placenta previa, so I'm pretty confident that y'all got that down pat. Okay, great. Let's go to question number 2. And I'm putting the rationales in the chat in case it's helpful for you to know the rationale. Okay. Okay, I see some answers coming in. Okay, let me see. I see Lakeisha, Julia, Jennifer. I'm gonna give Miss Kathy some more time. Okay, thank you, Miss Kathy. All right, let's break this question down for a moment. Okay, so the nurse is caring for a client who is 1 hour postpartum. So I'm thinking, man, okay, this is the golden hour. A lot has happened. The body is going through all these changes. We know that right after giving birth, the patient's going to feel really cold, right? There's probably going to be shivering, like that goes with it. All those physiological changes after childbirth. Now, the nurse observes a large amount of lochia rubra, and let me pause for a second. And if any of you have been to my office, I have a little display of lochia. Just because I think it's important to know that, let me just bring up a picture of lochia so you kind of get an idea of this. So lochia rubra, it's dark red blood. And I'm sharing, you should see the picture of the different lochias. Lochia rubra. So this is dark red and it's from birth and 3 to 4 days postpartum. And so it's like a really heavy menstrual cycle. They're going to have clots, small clots, smaller than a quarter, right? A quarter or smaller, that's what we're looking for. If it's larger than a quarter, that's a cause for concern. So the odor is going to be fleshy, just like menstrual blood. Now, lochia serosa, it's less red, right? It's going to be pinkish brown, and this is from 4 to 12 days after birth. And so this is a moderate or a small amount. Now, after that, the patient can have this lochia alba. And so this is yellowish white. And so this is from 12 to up to 3 weeks postpartum. And it's going to be gradually disappearing. It's going to become very scant. And scant is, very small amount. Okay. So this is an important thing for you to know these different kinds of lochia. That's really important when we talk about mother-baby kind of stuff. Okay. So again, this patient is 1 hour postpartum, and they have a large amount of lochia rubra and several small clots. Okay, so small clots are okay. And we're thinking the fundus is midline. That's good. That's where we want the fundus to be. If the fundus was not midline, I would ask the patient to empty her bladder, right? That would be one of the first things I would do. Now, the fundus is also firm. That is reassuring. That makes me feel happy because we know boggy uterus. I instantly perform that fundal massage, and I'm scared to death of postpartum hemorrhage, right? So far, these are normal findings in a 1 hour postpartum kind of patient. So because this is normal, I am actually going to document, okay, let me get blue here. I am going to document the findings, but I'm going to continue to monitor the patient because we know that 1 hour postpartum, we're taking vital signs every 15 minutes. And then in that second hour, depending on the mom, how the mom is doing, we continue taking those vital signs every 15 minutes or even every 30 minutes. But we'll continue to monitor her. But these are all normal. We don't have to notify the provider of this because these are normal findings. We're not doing any fundal massages because the fundus is already firm. And we're not going to encourage the patient to empty her bladder because the fundus is already midline. Okay, so I'm going to pause for a second to see if there's any questions, and I'm going to put the rationale in the chat. No questions? All right, those that missed it, do you see why now?
Yeah. So I knew, like, you massage for bogey fundus, right? I knew you massaged for there, but then I was like, oh, okay, well, the small clots is good. I don't know, but yeah, I get it.
Okay, yes. So yeah, boggy uterus. Yes, you're going to perform that fundal massage, and you're going to cup your hand right under the uterus. So your non-dominant hand would go to provide support, and then you will palpate. You'll be pressing because we want that uterus to become firm. So we're kind of, massaging it, and it's going to be like a deep kind of massage. It's not just like, little, just like you're tickling somebody. It's going to be a little tender for the patient, but again, that uterus is at risk for hemorrhage. Okay, and I see, Ms. Kathy, you said yes, so that's good. Okay, let's go to question number 3, please. Okay, Julie, I see your answer. Thank you. Okay, thank you, Kathy. Okay, Jennifer, I see your answer. Okay, Lakeisha, I see your answer too. All right, let's kind of break this question down because I'm seeing some different answers here. All right, so what's going on in this question? We have a newborn and they were just born. Okay, so literally, just maybe within that golden hour. So this is immediately. So they just like within seconds just came out of the birth canal. If it was by C-section or vaginal delivery, that doesn't matter, but they were just born. So after assuring a patent airway, what is the priority nursing action? So this tells me, okay, what is the most important thing in accordance with Maslow's hierarchy? Okay, so of course, newborns is a specific kind of thing that we're looking for. So our choices: administer vitamin K, dry the skin, administer eye prophylaxis, or place an identification bracelet. So let's kind of talk this through. So what do you all think about administering vitamin K? Is that the most important thing out of all of these four choices?
No,
No.
I don't think so.
No. Okay. So you're right. What about drying the skin?
I picked drying the skin
Okay.
because I figured like when a newborn is born, after airway, you want to get them warm. They put them immediately under the heater, right? To try to warm up, keep their body at a warm temperature. That's what I thought, but that's
Okay. So and you're right. We do want to dry the skin. We want to prevent cold stress on this newborn, because that's why they're dried, they're swaddled, they put a hat on because we can lose a lot of heat through our heads. So that is true, because what happens if this newborn does not keep their temperature, they have brown fat and they're going to try to burn that brown fat, but they don't have a lot, so they don't have a way to thermoregulate. So what's going to happen? They burn this brown fat, then they're going to end up having an increased metabolic demand that could lead to hypoglycemia. So cold stress is going to be the key. So when I think newborn, I think suction the nose, suction the mouth, and then my second thing that I got to do is to dry them off. And if they're not going to skin, right? If they're not doing that kangaroo care right then, because that helps them to maintain the temperature, like if they're on their mom or their dad or the grandmother, if the mom is not available, or some family member, then they need to be dried and swaddled and get that hat on to keep their heat in. Now, eye prophylaxis is important, but it's not more important than drying the skin. Placing an identification bracelet is important, and we're not going to let that baby leave that birthing room until they have an ID bracelet. But more importantly, we have to dry the skin. Okay, so if you ever see any questions like this is really, using Maslow's hierarchy. The airway comes first, then we're concerned about cold stress. Okay, any questions on 3? Okay, here's another question. Okay, I see some answers coming in. Okay. Okay, Julia, Kathy, Jennifer, I see your answers. Okay. Okay, so I see 3 answers so far. Okay, let's see, who am I missing? Okay, Lakeisha. Okay, excellent. So everybody got this one right. And let me just greet Maria Isabel. Hello, Maria Isabel. How are you doing tonight? Okay. All right, everybody got this one. Oh, sorry, Julie, I sent that just to you. I meant to send it to everyone. This is for number 4. This is the rationale. And it is D, right? So this is a patient, 7 weeks gestation, you know, during the first trimester and the third trimester, that's when there's a lot of urination going on with this patient, okay? All right, I'm not going to talk about this at great length because everybody got it right. I'm going to do one more question, and this is a rubella question, which is a pretty important concept. You could definitely see this for your test, I'm sure. Maybe not this test, but maybe future tests if you haven't gotten to this in your lecture. Okay, I see the answers coming in. Okay, it's looking good, looking good. Okay. Okay. Maria Isabel, I'm sharing my screen and we're doing question number 5. If you put your answer choice, what you think the answer is in the chat, and we'll just talk about it. Okay, perfect. Okay, everybody got this. Okay, so anybody want to tell us about the significance of rubella with pregnancy?
Because it's a live virus, you give a pregnant woman any live vaccine. So that's why you don't give it.
Mm-hmm.
And
Excellent.
right now I'm getting confused. But I know you can't give it because it's a live vaccine. But it was something else I was thinking of, but I'm not gonna say that because that's probably wrong and I don't want to confuse nobody.
Okay, but so you're right so far. And so I've got to tell you one more thing about this, because with rubella, when I think of rubella and pregnancy, I think of the torch infections. Have you all maybe heard of this before?
Nope, I haven't.
No, I've never heard of it.
Okay, maybe you are not up to that point yet in the classroom, but this is definitely something that you're going to know. And those of you getting ready for NCLEX, you got to remember this, please. So these torch infections, these are, you know, the acronym for 5 infectious diseases that can damage or harm that developing fetus. So T stands for toxoplasmosis. So kitty litter. Pregnant patients should not be handling kitty litter, even if they're using gloves, because in the larvae, in the stool of cats, these larvae of these parasites can actually survive, and this can cause issues with the developing fetus. So that's your toxoplasmosis. So if you see a question, a pregnant patient is changing kitty litter, wrong answer. No, no way. And they shouldn't do gardening either because of the danger of toxoplasmosis. Another infection that can damage potentially damage the fetus is going to be hepatitis. That's the O for other. Rubella, and that's why I wanted to make sure you knew these torch infections. And then cytomegalovirus, that's another one that can cause brain damage. And then herpes simplex virus. And remember too, don't let anybody kiss these babies, because if someone has a herpes virus, they kiss the baby can actually die, right? So that's really, really important. But torch infections, if you didn't learn it yet, you will, but this is something important you need to know in your mother baby kind of class. Okay, any questions? All right, I'm going to stop sharing and I'm going to go around the room to see if anybody has anything or anything to offer, anything else you'd like to see in the future. Lakeisha?
No, I enjoyed you going over, having a quick review for everything, and then the questions that helped.
Okay.
That's it.
Okay, awesome. Well, I'm glad to see you. Glad that you're here. Okay, I hope to see you again in future sessions.
I
Okay.
most definitely will be.
Okay, awesome. Okay, Jennifer?
No, ma'am, that you did a good job at covering it. It simplifies a lot of it for me.
Okay, fantastic. I'm looking forward to great results on your test. Okay, Kathy?
Another great tutoring session. I truly appreciate it. I got a lot out of this. I really did.
Okay, excellent. I am so glad. Okay, Julia.
I have no questions, but I really appreciate that you do put the questions at the end because it gets us kind of like thinking the way that we should be thinking for our tests.
Okay, awesome, awesome, awesome. Okay, Maria Isabel, I know you came in towards the end, but this is recorded, so I'll send the link to all of you who are here and the mother baby class, and also to Lakeisha. And if those of you don't know Lakeisha, she is a graduate. She's getting ready for the NCLEX.
Woo woo!
Congratulations.
Thank y'all.
Congratulations, Akisha.
Okay.